Okay, so I will going to talk first. Okay, thank you, Professor Sario. I would like to thank to the organizing committee to invite me to this meeting. So for this debate, cure versus control as first-line therapy in CML actually is it's a transplant versus TKI. So in my part, I will favor of control by TKI. So as all of you know that TKI has changed the treatment of CML in the past decades completely from allogeneic transplant or interferon to TKI. So for the last decades, we have aiming at to achieve major molecular response by first generation TKI Imatinib, and that can be achieved in the majority of patients. And now we with availability of second generation TKI, Nilotinib and Dasatinib, as presented by the Sario, now we can aim at the complete molecular remission. So the long-term survival at 8 years from IRIS trials, the overall survival is 85%, and if considering only CML-related deaths, 93%. So that's much better than the outcomes derived from transplant. This is the CIBMTR, the most recent one. As you can see that after 2001 for the CP, the 3-year probability of survival is only 70%, and to 6 years it drops to around 65% only. And so TKI has greater than 20% of survival advantage than stem cell transplant, and that mostly comes from the risk of the early transplant-related mortality. And for the surviving patients, still a lot of them live with chronic graft-versus-host disease, so they have a compromise of their quality of life. And if we follow for much longer, to more than 10 years, this from Fred Hutchinson data, you can see that there are continuing late mortality, probably from late complications or secondary malignancy. So that explains why in the most of the countries, the transplant numbers for CML has decreased dramatically. This is CIBMTR data. And currently, the treatment goal for CML by most international guidelines and most countries' guidelines is to achieve CCYR before 12 months and MMR before 18 months. And the second one is to prevent the emergence of resistance and progression of to AP or BC and maintain quality life. So this is a typical case, 54 years old male in 2006, have a CML chronic phase, and using the Imatinib 400 milligram per day, and after 4 years, he achieved sustained CMR now it's for greater than 2 years. Now we are considering to discontinue the drugs. And for some patients who did not have optimal response to Gleevec and sprite cell, we perform a transplant, and so. And 1 year after transplant, the disease relapse again. Still, the patient can be salvaged by another TKI, Tasigna, and achieve more than greater than 4 local reduction. So, for this case, it highlights that transplant for the resistant patient may not be the only solutions. And if we can find the right TKI, we can overcome the resistance. So what's the role for upfront transplant for CML in current phase? There are 4 possible situations. One is for some CML young patients who had poor social risk and low transplant comorbidity score. And the second one is for pediatric patients. The third one is a de novo onset of advanced phase. And the fourth is economic issues. There are only very few randomized clinical trials comparing upfront transplant with TKIs. This is the German CML Study IV. It's a multicenter randomized study including more than 1,200 patients. And for the previous analysis, they showed that the survival was inferior for transplant patients compared with a patient receiving Imatinib. But later on, they do a subgroup analysis and published on Blood 2010. And you can see that for this algorithm, they divide into 5 groups, and actually only less than 7% proceed to transplant. And for the first 2 groups, either transplant for a low EBMT score or transplant after Imatinib failure in CP1. Both groups had a number of 56 patients, only 4.5% of the whole cohort. And they do a much pair analysis compared with another group of inactively 106 patients. And surprisingly, they found no survival difference between these 2 groups if we start from the survival analysis from after diagnosis. And another surprising result is that after transplant, 3-year overall survival is 91%. And the treatment-related mortality is quite low, only 8%. And after transplant, 88% achieve a CMR. So that's quite good. Compared to previous transplant-related mortality, usually is between 20 to 30%. So, but the also conclusions is that allo stem cell transplant could become the preferred second-line options after Imatinib failure for suitable patient with a donor. Okay, so that's not applicable to the majority of patients. How about the childhood CML? This is published in Blood this year, how I treat the childhood CML. And the three authors has the algorithm for the CML newly diagnosed patient, and for CML chronic phase, they still recommend upfront TKI, either first generation or second generation TKI, and transplant only considered for patients who fail the first line or the second line TKI treatment. But for some countries, like in Asia, China, Thailand, India, and the others, not many patients are covered by the insurance for the TKI. So if money becomes the key issues, the doctors have to consider upfront transplant. And this is published in BBMT last year by Fang Xiaojun from Beijing People's Hospital. They can have excellent survival of the transplant. And another concern is that the late event for TKI, this is the hematopoietic, this is already shown by Serial, that some late event and late mortality concerns. And for the IRIS trial, after 8 years, 37% have not acceptable response to Imatinib. So we need second generation TKI to overcome these issues. This already presented. So second generation TKI to decrease the proportion to early progressions and achieve deeper and faster molecular response. And a majority of these MMR patients has greater than 4 log reduction, and CMR can be achieved in 1/3 of patients after 3 years of treatment. So now CMR can be a reality with a TKI, and the patient can have a relapse-free survival and drug-free, and the possible stop the drug and away from a fear of any cancer and a better quality of survival. And after discontinuation, 40% can have a relapse-free by a STEAM trial. So cost is not everything, value is. And for the developed Western countries, the 8 years medical cost between transplant and TKI was not so strikingly different. But for Asian countries, like in Taiwan, the transplant medical cost is around 35,000 for the first year, and for the 8 years, it's less than 100,000. So still is less than. Although our patients are 100% covered by the health insurance, but still it has a large burden to the insurance. But we need a safer parachute. For stem cell transplant, there are always a risk to get unpredictable morbidity and mortality. So for the patient, they can feel like normal and a better quality of life with TKI. They can walk in, dating, marry, get a pregnancy, and have children, and possible drug-free in the future. So for the 2012 treatment paradigm, allogeneic stem cell transplant could be the second or third strategy. So thank you for your attention.